Now we move to the AstraZeneca Symposium. The speaker in this symposium, the eminent Professor Dr. Ashraf Omar, وهو غني عن التعريف. Actually, he's an eminent gastroenterologist and hepatologist, will give a talk about treatment of esophagitis. It's a great honor to share this symposium with Professor Helmi Abbasi. دكتور حلمي، تفضل دكتور أشرف.
أتشرف إن أنا أكون مع حضراتكم النهارده الحقيقة في هذا السيمبوزيوم. بشكر أخويا الدكتور يحيى طاهر على المقدمة، وبتشرف إن أكون معاكم النهارده في موضوع مهم هو الأسوفاجيتس. أرجو إن يكون الصوت كويس واضح. الأسوفاجيتس is any inflammation, irritation or swelling of the esophagus. Esophagitis is mainly consequence of gastroesophageal reflux disease, one of the most common disease affecting the upper digestive tract. However, esophageal mucosa can also be targeted by some infectious systemic or chemical conditions. Eosinophilic esophagitis, which is a special form of immune-mediated inflammation of the esophagus, which is characterized by eosinophilic infiltrate, may be considered as well. So the most common types of esophagitis is reflux esophagitis, infectious, mainly fungal or viral, fungal by candidiasis, or viral by herpes simplex or cytomegalovirus. Eosinophilic esophagitis, pill-induced radiation or caustic esophagitis. Less common causes are Best's disease, graft versus host disease, Crohn's disease, which may affect the esophagus by in 0.2 to 3% of the cases, and in conjunction with the ileocecal Crohn's. Metastatic cancer esophagitis is also maybe reported. The symptoms are four main symptoms in such condition: dysphagia, heartburn, odynophagia, and chest pain. Chest pain should be differentiated from a cardiac pain, of course. Dysphagia is a difficulty of swallowing, and it's an alarming symptom because it raises a concern for the presence of a peptic stricture or adenocarcinoma arising on top of Barrett's esophagus. Heartburn is a symptom, a complex symptom, episodic substernal pain that is worsened after meals and relieved on and by antacid. So there is a link between the pain and the acidity, and often burning, and commonly radiates towards the mouth, frequently accompanied with bitter taste or salty taste. Odynophagia is a painful swallowing due to acute and severe form of esophagitis, typically with mucosal ulceration, aching or stabbing pain substernally, aggravated by the act of swallowing or even swallowing saliva. يعني لما العيان بيبقى عنده this kind of pain, usually بيبقى فيه a kind of ulceration in the esophagus. It is commonly due to infectious pills or radiation esophagitis. مهم جدا, it's very important to have an accurate clinical history because it might be the key for the final diagnosis. For example, when we have because of course the treatment depends on the underlying cause, and if neglected, of course there will be a stricture and or functional problem in the esophagus. So having a proper clinical history is maybe the key of the final diagnosis. For example, history of drug, and we have two kinds of drug, the NSAIDs and the steroids. NSAIDs may have inducing ulceration and severe form of esophagitis. Steroids of course may be accompanied with immune suppression and will be accompanied with infectious esophagitis. Of course, when there is a family history of allergy, we may think of eosinophilic esophagitis. If there is a history of irritable bowel syndrome, we may think of Crohn's and so on. So taking a history, proper history may be the key of the final diagnosis. And of course, the symptoms of the patient may suggest the diagnosis of GERD, and we may treat accordingly. So GERD, by definition, is the condition that develops when the reflux of stomach content causes troublesome symptoms and or complications. And 40% of cases of GERD may have an erosive esophagitis due to acid irritation, and only just 5% of the patients may have some complications. What are the risk factors of reflux? Of course, there is some points that may predispose to this kind of dysfunction, which is the transient lower esophageal sphincter relaxation, sliding hiatus hernia, low pressure of the lower esophageal sphincter, acid pocket, which is developed due to poor mixing of acid with chyme in the proximal stomach, increased gastroesophageal junction distensibility, obesity delaying gastric emptying. Of course, some conditions like in pregnancy, scleroderma, cigarettes, alcohol, peppermint, certain medications like the anticholinergics, beta blockers, bronchodilators, and so on. So there is a lot of risk factors that might predispose to a GERD with different severity. And one of the important points is that the GERD symptoms may be superimposed with other without reflux. So the GERD symptoms may be the same like patients with having some just simple symptoms without reflux esophagitis, like the burning, the heartburn, the epigastric burn, the epigastric pain, and the nausea, regurgitation, and so on. So, regards the frequency of heartburn, as you can see from this figure, we can figure that patients with and without reflux esophagitis having almost close frequency of heartburn, and again the same severity of heartburn with and without reflux esophagitis. Also, there is no correlation between the severity of the heartburn versus the LA grading. The Los Angeles grading is the ABCD grade. No correlation as well. Again, the epigastric pain have negative predictor of GERD, does not correspond with the presence of severity of reflux esophagitis. So the severity of reflux esophagitis across the LA grade has no correlation. This is very important. So when we have a patient's of symptoms that might suggest gastroesophageal reflux, we may rely on just the symptoms, and we may start in this nice figure. This is a very recent nice algorithm from Cleveland Clinic, recently published, that we can proceed and start with the proton pump inhibitor for 8 weeks. And of course, if there is a good response, we may go for tapering and maintain the patients on a low dose of proton pump inhibitor. And however, if the patient is having alarming symptoms like dysphagia, odontophagia, bleeding, anemia, weight loss, early satiety and vomiting, we may proceed immediately for upper endoscopy. And the endoscopy, accordingly, we may manage according to what we are going to find. If there is no response, so we may proceed for pH monitoring, and at that condition, we may optimize the treatment accordingly. If there is an abnormal monitoring, we optimize the medical therapy, and we may consider at that point surgical and or endoscopic therapies. If normal, we consider a functional heartburn or reflux hypersensitivity. So this algorithm may help how we can approach a patient with reflux disease. So we mainly rely on symptoms in that condition. According to meta-analysis, short course of proton pump inhibitor has a 78% sensitivity and 54% specificity in accurately diagnosed GERD. If typical symptoms resolve with an initial trial of proton pump inhibitor, GERD should be diagnosed and confirmed, and the patient should continue on taking proton pump inhibitor daily. The upper endoscopy only for patients with having alarming symptoms, as mentioned, and we may find at that point erosive esophagitis, strictures, Barrett esophagus, or we may find nothing. In 1999, Los Angeles classification system was published, and now it is the standard of method for classifying the cases of esophagitis. And for patients with eosinophilic esophagitis, we may have to do a biopsy for this condition. This is, of course, what we call the Los Angeles classification system. We all know all the 4 grades, the A, B, C, D, according to the mucosal break, and the extension of this break, and other superficial, deep, or deeper. And this is the endoscopic picture of the different stages, A, B, C, and D. We all know this classification. Most of the cases rely on the LA grade B, maybe more than 40% or almost close 40% of cases are rely on Los Angeles grade B. This has been mentioned when we do pH monitoring in patients with persistent symptoms and normal finding on endoscopy before we go for surgical or endoscopic intervention. We have 3 options, either 24-hour transnasal pH or pH impedance catheter or 48-hour Bravo wireless capsule. And this is the clinical, for the clinical practice. In clinical practice, the pH testing is performed with the patients off PPI. We should stop PPI therapy when there is a low clinical suspicion for GERD, whereas the pH impedance testing is performed while the patient is still on the PPI therapy when there is a high likelihood of GERD to evaluate the refractory symptoms. So for the treatment of the GERD or the esophagitis due to GERD, the most important thing, the most important issue in the treatment is 2 issues: the lifestyle modification and the drug therapy. For the lifestyle modification, rely on 3 main issues: the weight loss, diet, and the sleeping position. We have to elevate the head of the bed 6 inches, stop smoking, excess alcohol consumption, reduce dietary fat, reduce meal size, bedtime snacks, weight, avoid the chocolate, the caramels and peppermints, and so on, coffee. All these may increase the acid introduction and increase of course, the inflammation of the esophagus. And of course, with the lifestyle intervention, if fail or accompanying with the lifestyle modification, we may add the drug therapy, which is mostly the proton pump inhibitor and or the histamine 2 receptor antagonist in some instances, and the antacids. For the proton pump therapy, it's the drug of choice of treatment to relieve and healing and maintenance of erosive esophagitis. It inhibits the gastric acid secretion by activating the hydrogen potassium ATPase molecule of the parietal cells. As compared to the H2RA blocker, PPI have been shown to provide improved healing rate and fewer relapses in patients with erosive esophagitis. And in meta-analysis, when you are reviewing the meta-analysis, esomeprazole was shown to increase the probability of healing erosive esophagitis over the other proton pump inhibitor at 4 and 8 weeks. After the initial 8-week course of therapy, most of the patients with GERD should attempt to take the lowest dose required to manage the symptoms. We should put the patient on a small maintenance dose. And the patients need long-term proton pump therapy, patients with severe erosive esophagitis, grade C or D, patients with Barrett's esophagus, and patients with peptic stricture. H2 blocker, H2RAs appear useful in GERD for controlling nocturnal acid breakthrough. We sometimes put an H2 at the evening. In the morning, we put proton pump, and in the evening, we may put one of the H2RAs to control nocturnal acid breakthrough. Antacids also may be added to eliminate the sense of heartburn and the sense of severe pain. There is an important study, which is the EXPO study, studying it's mainly two studies, related to evaluating the healing power of the erosive esophagitis and the resolution of GERD. And the other research is for the maintenance. So the first one is for healing. It's a randomized controlled trial comparing esomeprazole 40 versus pantoprazole. It's a one-by-one randomization, double-blind, multi-center study, intention to treat. The primary endpoint was proportion of patients with healed erosive esophagitis followed 8 weeks treatment. Secondary endpoint, 8-week healing rates by baseline erosive esophagitis severity, observation of the healing rate at 4 weeks, and observation of healing rate at 4 weeks by erosive esophagitis severity at the baseline of LA grading. Of course, this is one of the results. The healing rate was significantly higher in the esomeprazole group, 96 versus 92%. Also, the healing rate across all the LA grades of the erosive esophagitis, significantly better in the ESO group versus the panto group in different grades of LA. Also, the sustained resolution of the heartburn during treatment with ESMO is significantly higher, 76 versus 70% versus the pantoprazole group. When we look to the other study, the patients for maintenance, already patients had a complete healing phase. So after healing phase, patients put on a maintenance phase esomeprazole 20 versus pantoprazole 20. And the primary endpoint was proportion of patients in endoscopic and symptomatic remission. Secondary endpoint, endoscopy finding at month 3 and 6, and proportions of patients in endoscopy and symptomatic remission versus the baseline LA grading. And as we can see in this figure, there is the endoscopic and symptomatic remission were significantly more with the ESO versus patients on Pento, 78 versus 75%, which is very significant. Also, ESMO 20 was higher versus Pento in symptomatic remission across the all LA grading, as seen in this figure. Again, the ESMO was significantly more effective than pantoprazole for maintaining symptomatic remission at 6 months for maintenance therapy. So in conclusion of this study, both treatments were well tolerated. The proportion who experienced serious side effects were almost equal in both groups, about 33% in Pento and esomeprazole in both groups. ESMO 40 milligram provide more effective healing power for erosive esophagitis than the pantoprazole at 4 and 8 weeks of treatment, faster and more effective resolution of heartburn. Also, it is better effective in maintenance therapy following the initial healing of the erosive esophagitis and relief gastroesophageal reflux disease symptoms. In general, the adverse effect of proton pump inhibitor has been revised and recently, and the only risk after treatment of more than 3 years are just increased the risk of enteric infection, and there was no association between long-term proton pump inhibitor use and myocardial infarction, small intestinal bacterial overgrowth, pneumonia, gastrointestinal malignancies. We come to another important issue, which is the infectious esophagitis. Usually, infectious esophagitis are with patients, immune-compromised patients with history of immune suppression, steroid therapy, recent antibiotic use, or systemic illness that supports this diagnosis. So taking a thorough history is very important in this issue. Although patients may be asymptomatic, the typical symptoms include dysphagia, odontophagia, heartburn, retrosternal discomfort or pain, nausea, vomiting, fever, sepsis, abdominal pain, epigastric pain, sometimes hematemesis according to the severity of infection, anorexia, weight loss, and cough. So this is the treatment of the different types of fungal esophagitis according to the etiology. for the fungal infection, which is usually candidiasis. The treatment will be with fluconazole. The treatment is with either fluconazole, acyclovir for viral, ganciclovir for cytomegalovirus, antacid proton pump inhibitor, and this is the only treatment. Acyclovir for herpes, HIV, esophagitis, varicella, or Epstein-Barr virus, ganciclovir for cytomegalovirus, and fungal infection for fluconazole for fungal infection. Bacterial esophagitis will be treated after proper diagnosis with broad-spectrum antibiotic with aminoglycoside, beta-galactamase antibiotic with aminoglycoside. And in this figure, the different histopathology of the ulcers in the esophagus, the fungal esophagitis, it will be a shallow and dirty with dirty edges. The herpes simplex and cytomegalovirus, clean, clear ulcers, sometimes deep, mainly superficial ulcers. For the non-reflux, non-infection esophagitis, like Behçet disease, corticosteroids, and azathioprine, graft versus host esophagitis, dilatation, anti-reflux, proton pump, corticosteroids, and others. Inflammatory, like in Crohn's disease, esophagitis, which is rare, corticosteroids, dilatation. Eosinophilic esophagitis will be discussed. Metastatic cancer and radiation therapy will be proton pump and others. For pill, radiation esophagitis and caustic esophagitis, so of course the main treatment would be with proton pump inhibitor, and these some figures of different types of non-reflux, non-infection esophagitis, like corrosive esophagitis, Crohn's esophagitis with aphthous ulcer, pill-induced, and NSAIDs esophagitis, which in a way characteristic for this kind of injurious cause. For eosinophilic esophagitis, as we know, it's a very characteristic immune-mediated allergic condition that may be present, and the mast cells in the lining of the esophagus may release some substances that may damage the epithelial cells, and it has a very characteristic, the esophagus has a very characteristic, and the figure shows a very characteristic shape and photo of the eosinophilic esophagitis, the trachealization of the esophagus, like it looks like the trachea, because there is a linear furrows and there will be some circles like in the trachea, with sometimes a decrease in the diameter, and sometimes there will be stricture. Of course, it's a very important issue, and recently the American Gastroenterology and joint with the Task Force on Allergy and Immunology in May 2020 put guidelines, clinical guidelines on the management of eosinophilic esophagitis, and the first line treatment put 3 or 4 important points for the treatment of eosinophilic esophagitis: proton pump inhibitor, topical corticosteroids, elemental diet, either empiric or allergy testing based, empiric 6-food elimination diet, and endoscopic, of course, endoscopic dilatation for patients having stricture. For maintenance, of course, the patient should remain on topical corticosteroids and who achieved remission, of course. And lastly, there is some novel biological therapy which is not been approved. It should be only in the context of clinical trial, like anti-interleukins 4, 5, and 13, and TNF-alpha inhibitor. And these are some of the important upcoming novel treatment options for the eosinophilic esophagitis. Will be soon available. New budesonides, the budesonide oral suspension and budesonide oral dispensable, also interleukin 13 and 4 and 5 inhibitors, and monoclonal antibodies and TNF. A lot of novel biological treatment that might change the whole story and may improve the treatment success for patients with eosinophilic esophagitis. And this figure or this algorithm recently published a few months ago about the outline of the recent management of eosinophilic esophagitis according to the recent guidelines, mainly three main issues: the diet, medication, and the new novel biological treatment. Diet, elimination diet, elemental diet, elimination diet by 6-food elimination diet, elemental diet by step-up approach, including 2 or 4 food elimination, allergically based. In medication, mainly rely on proton pump inhibitor with topical corticosteroids and with the newly novel corticosteroids, of course. And lastly, the clinical trial novel corticosteroids and the biological agents as mentioned in the last table. Thank you very much.
Thank you, Professor Ashraf, for this elegant updated presentation about treatment of esophagitis. Any comments or questions, Dr. Ashraf, Dr. Fathallah, Dr. Ahmed?
كنت أسأل سؤال بس دكتور أشرف، ازاي بتشخص البكتيريا الاسوفاجايتس؟
ده سؤال مهم جدا طبعا. البكتيريا طبعا في ورك اب بيتعمل. اولا كون ان بناخد هيستوري ده مهم جدا من العيان، لانه بيفيد جدا في لو كان العيان اميون كومبرومايز او كان بياخد ادويه قبل كده ولا لا. ثانيا في ورك اب كامل بيتعمل من اول السي بي سي وللابر اندوسكوبي، ولما بتشوف اي ليجن بتاخد منها بايوبسي وبتحللها. طبعا في حالات زي مثلا زي التي بي من الحاجات الصعبه جدا، الحاجات كلها تشالنج. يعني بكتيريا الاسوفاجايتس من الحاجات التشالنجينج في الدايجنوزس، مش من الحاجات السهله. مش بتعتمد على وان ايشو. عموما الاسوفاجايتس عموما من الحاجات اللي هي التشالنجينج في التشخيص، بتعتمد اساسا على مش وان فاكتور، بتعتمد على كذا حاجه، بدءا من الهيستوري ومن الابر اندوسكوبي، من بعض اللاب ورك اب اللي بتساعدك في التشخيص النهائي. لكن للاسف ما بتعتمدش على حاجه واحده، سبوت دايجنوز. طبعا زي ما حضرتك عارف دكتور صدقي، انت يعني خبير في المناظير وبتشوف القصص ديت يعني. وعموما البكتيريا الاسوفاجايتس ما هياش كومن، مش من الحاجات الكومن فايندنج، مش زي الاذر كوزز اوف اسوفاجايتس زي الايروزيف اسوفاجايتس وزي الايزونوفيليك اسوفاجايتس. حتى يعني الايزونوفيليك اسوفاجايتس ممكن يعني فيري انفريكوينتلي بتتشاف وليها كاركترستيك بيكتشر. اول ما بتحط المنظار بتديك الاندوسكوبيك بيكتشر that might suggest eosinophilic esophagitis.
Dr. Ashraf, actually you give us interesting data about reflux esophagitis. You have any advice how to avoid or prevent reflux esophagitis?
ده طبعا سؤال مهم جدا، وده اهم حاجه بالنسبه للعيانين. هو when we go back to the predisposing factors that might increase the possibility of reflux esophagitis، هنلاقيها حاجات ممكن يعني نحاول نساعدها او نحاول to avoid it، وفي حاجات inevitable. يعني المشكله في السفنكتر دي بتبقى واللو بريشر لو اسوفاجيال سفنكتر، دي من الحاجات الصعب اللي هو الواحد يقدر يتعامل معاها. الهياتس هيرنيا من الحاجات اللي one of the major predisposing factor في الريفلكس اسوفاجيتس. لو حاجه كبيره وليها ممكن surgical intervention، لو big hiatus hernia that might interfere وعامله severe regurg وعامله مشكله كبيره قوي that may predispose to Barrett's esophagitis, we may proceed for surgery. الاوفر والobesity من الحاجات اللي we should consider it كبredisposing factor. الحقيقه برضو العيانين والكنترول اوف دايت، watch what we are going to eat. الاكل ونوعيه الاكل وكميه الاكل الحقيقه بتفرق كتير جدا مع العيانين، وبتقلل الريفلكس وبتقلل السيمتومز مع العيان. يعني مجرد ان العيان يكنترول كميه الاكل ونوعيه الاكل، ويرفع السرير فعلا مخدتين كده تحت ظهره، بتفرق جدا زي ما حضرتك عارف يا دكتور يوسف، طبعا حضرتك استاذ في الموضوع ده، وبيفرق جدا مع العيان انك حتى لما بتديله البروتون بامب انهبيتور بيبقى بيعمل رابيد ريليف. لكن الى حد ما سؤال حضرتك is very challenging. بنحاول بقدر المستطاع ان احنا to overcome ال predisposing factors اللي هي بتؤدي الى الجيرد وبتؤدي الى الايروزيف esophagitis.
حضرتك أشرت ال different causes of esophagitis in general، ومنهم caustic and pill-induced esophagitis.
أيوة.
Do you think that proton pump inhibitors have a role in the management?
طبعا ده سؤال مهم جدا. انا في رايي ان طبعا البروتون بامب انهبيتور من الحاجات المهمه، الانتي اسيد من الحاجات المهمه، وممكن برضو ال H2RAs من الحاجات المهمه، الكومبايند ثيرابي، لانه زي ما حضرتك عارف الحاجات اللي بياخد الانتي اسيد لما بيشربه وبينزل بيعمل كوتنج لكل الاسوفاجس، ده بيعمل ريليف للبين وبيدي فرصه للهيلينج اوف الحته الانفليمد او الالسر الموجوده نتيجه البيل انديوست اوسوفاجايتس. فالان بعتبر ان الانتي اسيد مهم جدا بجانب البروتون بامب، لكن مش البروتون بامب بس، هي اتس مالتي فاكتوريال، لكن البروتون بامب از one of the important factors في التريتمنت، لكن مش هو الميجر فاكتور في التريتمنت. اتفق معك.
Would you add something else other than the antacid؟
بدي انتاسيد وبدي وبدي كمان ممكن H2 كمان كومبايند مع الانتاسيدز. ما اعرفش خبره حضرتك
ايه. What do you think فتح الله؟
احنا ممكن ندي ريبا بجلايد اللي هو الميوكوستا، وممكن ندي حاجه تقلل الريفلكس في اسيد زي بروكانيتيك مثلا ولا حاجه.
يعني modification of the style of life is very important,
طبعا.
including loss of weight or decreasing body weight and changing the bad habit of diets, of eating everything, and avoid some diets like acidic diets, like some people like to take some acidic diets during the diet habits they have.
وانت عارف يا دكتور يسري
like acetic acid and something like this.
الناس كتير قوي اللي هم الاولد ايج بالذات هم المعرضين اكتر للبيل انديوست اوسوفاجايتس، لان هم بياخدوا الادويه بطريقه غلط، بيبقى نايم.
any type of pill can cause esophagitis.
الفيبرامايسين بالذات يا بيه.
Yes, this is the most famous example for pill-induced esophagitis. Sometimes I did endoscopy for patient taking this pill without enough water.
بالظبط.
It gets stuck into the esophagus and cause severe ulceration. When you do endoscopy, you suspect malignancy from the severity of the ulceration it induced.
Especially in the old age.
Yes.
Old age بياخدوه هم نايمين، بيبقى قاعد كده واخد نايم على السرير وبياخده without enough water.
Do you see monilial esophagitis frequently? And what will you do if you see a patient with severe monilial esophagitis?
طبعا المونيلايسيس طبعا بنشوفها الحقيقه very infrequent، وخصوصا مع الاميون كومبرومايز. يعني usually السيروتيك patients المنظر المعتاد اللي احنا اللي بنشوفه infrequently end stage liver disease immune compromised patients، وبيجي لنا dysphagia, retrosternal pain, sometimes difficulty with swallowing. نعمل له upper endoscopy فبنلاقي extensive monilisis esophagitis، ودي بنشوفها الحقيقه very infrequently. كذلك الناس الاميون compromised، في بعض الناس الناس اللي هم diabetic on steroids، الناس اللي transplanted ساعات بنشوفها سواء liver transplantation أو kidney transplantation immune compromised. Sometimes they may develop monolysis.
candidates.
بالضبط.
Yes. And HIV patients receiving steroids, diabetics, all بالزبط. These patients may have candidates.
بالضبط.
Professor Ahmed Zaid, do you see many cases of pill-induced esophagitis?
Sometimes we may see pill-induced esophagitis, as you mentioned, Professor Yusri and Professor Fathallah. Vibramycin is the most common cause. عشان كده احنا دايما بننصح البيشنت اللي هو بياخد فيبرامايسين ان هو ياخده هو ستاندنج، ما يبقاش نايم ولا على جنبه، زي ما قال دكتور اشرف من شويه انه الالدرلي بوبوليشن بياخدوا الادويه بطريقه غلط. فده بننصح البيشنت دايما بالذات وهو بياخد الفيبرامايسين ياخده مع كوبايه ميه كبيره جدا ويبلع ويتاكد ان هو بلع البيل كويس جدا، لان هي مشكلتها ان هي بتعمل كونتاكت يوجوالي على اللور اند اسوفيجاس وبتعمل الاسوفيجايتس. دي يمكن اشهر سبب للبيل انديوزد اسوفيجايتس. ويمكن برضو الحاجات اللي بتستخدم في الاوستيوبروزيس زي الالندورينيت برضو لها علاقه، برضو تعمل برضو نفس القصه دي، بس اشهر حاجه الدوكساسايكلين.
بالظبط بالظبط.
دكتور اشرف، what's your recommendation for acute caustic induced esophagitis? What's your plan of treatment?
ما بقيناش نشوفها ما بقيناش نشوفها زي زمان
في البيدياتريكس. بنشوف في البيدياتريكس اونلي يعني
كوبايه اللي بيفتكرها
بيشرب البوتاس،
بيشرب البوتاس بدل اللبن. ما بقيناش نشوفها زي زمان يا دكتور يسري الحقيقه.
لا بلاش نشوفها كتير، الناس عارفين دلوقتي.
ناس عارفين.
دكتور يسري بيقصد في الاكيوت ستيج، لو حضرتك
اكيوت ستيج
وهو لسه ستيل في السريشن قبل
هو بلعها النهارده وجالك تاني يوم.
يعني
والله هي
اندوسكوبيك تريتمنت.
ايوه، هي امه بتتصرف صح، بتروح مشرباه كوبايه لبن على طول وتروح مشرباه على طول اي حاجه. واللبن طبعا هو اتس ان الكالاين، او مش يعني بيعمل سوذنج لموضوع الحرق ده تمبوري لحد لما يبتدي يروح المستشفى الحقيقه ويبتدوا يعملوا مع المانجر. لكن انا الحقيقه ما شفتش حالات بقى لي فتره طويله جدا كوستيك اوسوفاجيتس الحقيقه.
شفت حالات يا فتح الله من الكوستيك اوسوفاجيتس؟ Or you managed case like this؟
لا انا مش اصلا قلت قوي دلوقتي. قلت قوي يعني.
دكتور احمد شفت حالات زي كده؟
لا شفت حالات كرونيك مش اكيوت طبعا يعني.
لا الاكيوت لا مش قلت خالص.
قلت طبعا.
دكتور اسالك سؤال يا بيه. لو جالك عيان كلاسيك هيستوري اوف بيل اندوست السريشن، يعني بلع الفيبرامايسين من غير ميه وجالك بين، تعمل له منظار ولا بتدي تريتمنت؟ بيجوا
يعني الهيستوري، لو الهيستوري سجستيف خد بالك I will start treatment immediately, but I would like to have a look on the ulcer. I did it for many patients because I was in doubt about the history of the patient. And when I did endoscopy, I was surprised by the shape and the type of ulceration. It was horrible actually.
And you prefer to do endoscopy?
I prefer just to know what's happening there.
دكتور اشرف برضو في سؤال بعد اذن حضرتك. دكتور يسري من شويه سال على البيشنتس ويز سيروزس اللي بيجي لهم مونيليال اسوفاجيتس. هم طبعا ممكن يجي لهم مونيليال اسوفاجيتس، هربيتيك اسوفاجيتس، سي ام في انديوز لايك ذس. لو كان البيشنتس دول عنده لارج ريسك فيرسز، وات ويل بي يور بلان فور تريتمنت؟ يعني عنده لارج ريسك فيرسز وفي مونيليازس او هيربال اسوفاجيتس، هنعمل له باند لايجيشن ولا هنسيبه؟ اذا كنا هنسيبه يعني وي ويل بوستبون فور هاو لونج؟
ده سؤال فيري انترستنج. انا بشكرك دكتور زيد على السؤال الجميل ده. طبعا يوجوالي احنا ما بنعملش باند لايجيشن في اي during active esophagitis whatever the etiology، سواء candidiasis او other cause of esophagitis. فبنتريت immediately prompt extensive treatment لحد ما بيبقى فيه complete resolution للانفكشن and we may proceed للupper endoscopic band ligation. طبعا انا عارف ان السؤال ده فيه كده في مغرز عشان عايز توقعنا فيه يعني، لان طبعا it depends طبعا على الجريد اوف فيرسز. نفترض انها impending rupture، يعني طبعا ما انا لو سبته ما هو ممكن يفرقع ولا حاجه. فطبعا دي بتبقى محتاجه يعني judging وايفالويشن دقيق جدا. هل ابروسيد فور باندنج ولا استنى الانفكشن ولا اعمل باندنج وابتدي على طول السيستميك ثيرابي؟ دي محتاجه الحقيقه جادج. لكن انا ماي سيلف هتلكك ان انا ما اعملش باندنج during الاكتيف انفكشن.
هو السؤال مش كده يا بيه، السؤال تعالجه ازاي؟ واحد سيروتيك وعنده فانجل انفكشن تعالجه ازاي؟ هو ده السؤال. الانتي فانجل دي اساسا لها
طبعا وانت برضو مع حضرتك لو سبته ما هيخش بقى في سيستميك كانديدايزز بقى وكانديزوزس بقى، ده هتبقى خلاص ويخش في سبتيميا.
المشكله دي.
Thank you Professor Ashraf for your elegant presentation.
شكرا جزيلا.
Thank you Professor Fathallah. Thank you Professor Ahmed. We move to the last symposium today, Ramida Symposium. The speaker will be Professor Fathallah, who will give a lecture about Helicobacter update, and may share this session with Professor Helmi Abaza. Professor Helmi Abaza.
ايوه انا معاك اهو.
The session will start.
أنا معاك.
Yes, Professor Fathallah Sidqi will give a lecture about Helicobacter update. اتفضل دكتور فتحالله.
مش عايز يعمل شيرنج برضه بنفس الحكايه.
لا بقى
يا دكتور حلمي، برحب بحضرتك يا دكتور حلمي عشان وحشني.
اهلا والله اهلا دكتور اشرف.
لو في حد
منور وحاجه فيري اليجنت برزنتيشن.
ربنا وحشني والله جدا، ربنا يخليك.
والله استفدنا كتير جدا جدا يا اشرف، شكرا جزيلا.
ربنا يجمعنا على خير قريبا ان شاء الله.
امين ان شاء الله. شكرا يا حبيبي.
ميرسي يا فندم، متشكر قوي.
اهلا وسهلا.
ميرسي يا دكتور يسري.
شرفتنا يا اشرف.
ربنا يخليك يا حبيبي.